Elizabeth has a background in public health with master's degrees from the London School of Hygiene and Tropical Medicine and the London School of Economics. In her current role, Elizabeth works with a wide range of community partners in the development and delivery of HIV prevention programming, interventions, and policy. And our second speaker will be Dr. Ryan Watson. So Dr. Ryan Watson is a postdoctoral fellow at the University of British Columbia, and he received his PhD from the University of Arizona in Tucson, Arizona, and received his BA at UCLA in Los Angeles, California. His program of research focuses on LGBT youth and their experiences with families, at school, and coming out. He's co-investigator on a $2 million National Institutes of Health grant and the principal investigator of a project that investigates the casual sex experiences of sexual minorities. He teaches human sexuality twice a year for the UBC Psychology Department. And our third speaker of the panel will be Dan Allman, who is an assistant professor at the Dalla Lana School of Public Health and co-director with Professor Ted Myers of the HIV Social, Behavioral, and Epidemiological Studies Unit. His scholarly work focuses on the social and structural production of risk and well-being, particularly for those who are considered marginal, vulnerable, or peripheral to a society's core. At the University of Toronto, Dan teaches a unique cross-disciplinary course in HIV prevention research. Dan has led roles in Canadian community-based participatory and collaborative studies like the Winnipeg's Men's Survey, the Ontario Bisex Survey, the Ontario Men's Survey, MTRAC, and Male Call Canada. His earliest writings in HIV include the monograph M is for Mutual, A is for ACTS, Male Sex Work and AIDS in Canada, 1999, written in partnership with Health Canada, AIDS Vancouver, and the Sex Workers Alliance of Vancouver, and Concepts, Definitions, and Models for Community-Based HIV Prevention Research in Canada, 1997, written with Ted Myers and Rhonda Cockrell. His most recent publication in the Journal of Anthropology and Medicine provocatively problematizes the very community centrality in HIV research that he has long promoted. So we will start with Elizabeth.
Thanks. So this is a bigger room than I expected. Makes me a little nervous, but I think as long as you guys don't ask me math questions, I'll probably be okay. So no throwing out anything, please. I'm going to talk to you today about an HIV intervention that I've been working on for the last year or so. The project's about improving access to primary care for gay, bisexual, and other men who have sex with men by supporting family physicians to provide safe and appropriate care. And while this is a positive outcome in and of itself, we also believe that improved access to primary care will have an upstream impact on the vulnerability to HIV that GBMSM experience while trying to access primary care based on addressing stigma and marginalization in that context. Okay, just making sure it works. Before I get started, I'd like to acknowledge a number of folks, our partner UBC Continuing Professional Development for their contribution to the project, our GBMSM Continuing Medical Education Working Group, and the webinar and workshop facilitators, presenters, and content developers, though I'm not going to read out all their names because it's a bit of a long list. I'd like to give a little bit of a background before I get into what the project's all about, just sort of about why we're involved in this work. So in 2013, VCH Regional HIV Services underwent a significant redesign, and as part of this redesign, additional resources were allocated to support HIV prevention policy, programming, and intervention development and delivery. And we subscribe to a combination prevention approach to HIV prevention with a particular focus on structural prevention. So thinking back to the keynote address earlier, we're looking at ways of addressing particularly structural stigma, but other forms of structural biases. So recognizing that the HIV epidemic in Vancouver disproportionately impacts some populations, particularly gay, bisexual, and other men who have sex with men, we're really committed to developing and implementing structural HIV prevention interventions that address the context within which health is produced and reproduced. And what I mean by that is we look at different kinds of interventions, for example, that might address changing legal environments to make safer behaviors easier. Examples of that are things like the decriminalization of sex work or drug use. And in the context of HIV, it means we're looking at things like stigma, marginalization, and institutionalized homophobia. Oops. Okay. Sorry, I'm not sure what's going on. There we go. So the release of the PHO report, Sex, Stigma, and Society, and the most recent data from the Sex Now survey, as well as some discussions that we've had with folks in the community, really helped us to both identify the need and the opportunity that we had to improve access to primary care for gay, bisexual, and other men who have sex with men. And we, as I mentioned, believe that by improving access to primary care for GBMSM, we can help reduce some of the HIV vulnerability members of this community experience, as well as facilitate access to HIV testing and treatment as needed. So one of the ways that we can do this is by creating opportunities for physicians to improve their ability to provide safe, competent care for GBMSM. And so I pulled out a few, I feel I'm having a little technical difficulty in that my slides are advancing on this computer, but not on the screen. Take a little minute to figure out what's going on. Great, thank you. So I just wanted to highlight a few of the pieces of information from the PHO report and the Sex Now survey that helped us to inform some of the decisions we made. So from the PHO report, some healthcare providers are poorly equipped to provide culturally sensitive care and or may not be knowledgeable about health issues common among gay and bisexual men. And when physicians are perceived as being gay-friendly, a better physician-patient relationship will ensue and more appropriate care will occur. And from the Sex Now survey, we know that 14% of men who have sex with men have dropped a care provider in BC because of perceived negative attitudes. And this is just some additional data from the Sex Now survey about being out to your care provider. And it demonstrates that while there's a high percentage of GBMSM who are out to their care provider in the municipal Vancouver area, in the Vancouver coastal region as a whole, which includes Richmond, the North Shore, Sea to Sky, up to the Central Coast, the percentage of GBMSM not out to their provider ranges from about 20 to 55%. So this is not an insignificant number of folks. So informed by what we know from the reports, we also conducted an assessment to determine physician needs, and we found that family physicians have few opportunities to enhance the provision of care for GBMSM, and currently there's no continuing professional development offerings that relate to this topic offered in BC. And recognizing this gap, we approached EBC Continuing Professional Development to partner to develop an accredited curriculum for webinar and workshops about the health of gay, bisexual, and other men who have sex with men. So our project's divided into 4 distinct phases, and I'm going to spend the rest of the presentation talking us through the process as well as focusing on our preliminary evaluation findings. So the first phase was to identify in a concrete way the learning needs of family physicians. And those of us involved in the project had our suspicions about what those might be, but we needed to take an objective and methodologically sound approach to determine what the needs actually were. So in order to do this, we, along with our working group, developed 4 research questions to guide our work. I like to think of this slide as, how many times can I say GBMSM in a single slide? So question 1, what are the gaps in family physicians' knowledge about GBMSM care? How comfortable are family physicians caring for GBMSM patients? What skills, information, and tools do family physicians need to improve care of GBMSM patients? And are family physicians interested in attending CPD sessions on GBMSM health, and what might this look like? So we took a qualitative approach to our research and conducted 2 key informant interviews and 2 focus groups. Our key informant interviews are with a nurse practitioner who specialized in the provision of primary care for GBM-SM patients. And our second interview was with a research director from the CBRC, who I think is here today. Many of you know him. And our focus groups were with a mix of naive and experienced physicians in terms of providing care for GBM-SM patients. And all of the work that we did was both guided and reviewed by our GBM-SM working group. And so based on our research questions, we developed a bit of a focus group protocol that looked at a range of things from physician familiarity with terminology, all the way to sort of what kinds of skills and information and tools might they be looking for to improve their own practices. So I'm having, I think, that same technical difficulty. I can keep going. I don't know how many of you care about the slides. I'll just keep going. So the key informant interviews and focus groups were transcribed by a research assistant, and she then went on to theme them. And as we were doing this, 5 sort of core areas of focus emerged to consider for our curriculum development, the first of which was about identity. And sort of the key points that emerged about identity were that sexual identity in particular is complex, and that GBM-SM folk are not a homogenous population, and just like anybody else. Sorry, I can't see my speaking notes now. And I did prepare in advance, but not that far in advance that I can do this, like just without them, I know. Cool, thank you, that's fine. So, as I was saying, gay, bisexual, and other men who have sex with men, just like any other group of folks, have a whole range of different health issues, and that is something to keep in mind, as well as not making assumptions about behavior based on identity was one of the other big themes that came up. In terms of the second theme, it was around language and sort of what are the skills how can we help physicians build skills around asking and taking sexual histories comfortably, how to use non-assumptive language, how to be non-judgmental and open in the process that they are engaging with their patients. And because it was physicians, unsurprisingly, health issues were a topic of key interest for them. And the areas that they were particularly interested in were around any unique STI needs, sexual health in general, but also aging, substance use, and mental health needs. So in general, the consensus from physicians is that they were looking for additional supports around these topics. The fourth theme was about the clinic space itself and how to make a space safe and open, particularly focusing on the role of other staff that clinics might engage. One that came up a lot was the role of the medical office assistant and privacy and confidentiality. And the final theme was about coming and being out and acknowledging and trying to understand that it's a complex process, and it really impacts how folks engage with the healthcare system and with their providers, and understanding that it isn't black and white and that it may be fluid, and not making judgments based on a particular instance in time. So from this, we started to work on developing a curriculum for a webinar and a workshop. And the idea was to do this in order to get accreditation, which is sort of a bit of an incentive for physicians to come and take the course, because they need X number of credits every year in order to maintain their credentialing. So working with our working group, we came up with a series of 5 learning outcomes. 4 of which relate to both the webinar and the workshop, and the 5th, which is specifically for the workshop. And they are to gain skills to improve the care of GBM-SM patients, to understand the impact of social context on GBM-SM patient health, to identify common health issues experienced by GBMSM patients and their implications for care, to utilize resources and connect GBMSM patients to appropriate supports. And this is the one that's for the workshop specifically, which is to critically examine and reflect on the care of GBMSM patients in your practice. So these are the learning objectives that have informed our process going forward. And we have additional learning outcomes that are associated with each topic within the webinar, but I'm not going to get into that detail here, mostly because I suspect none of you really want me to read a bunch of more slides out loud. The webinar covers 3 core topics, the first of which is looking at epidemiology and at a population level, what is different for GBMSM patients, looking at the social context of GBMSM health, and presenting a case study of a complex client who focusing on sexual health, mental health, substance use, aging, and having an emphasis on communication and the creation of safe space. So, we tried to cram everything into a 20-minute case study. And the workshop expands on the topics that we cover in the webinar. Our hope was to have the 2 really complement each other, and for the webinar to be a bit of a taster to convince or encourage physicians to invest their time in learning with us going forward. And so in addition to the topics covered in the webinar, the workshop discusses GBMSM life course and specific health needs at different ages. It has a larger section on communication and offers 3 case studies that cover STIs, mental health, and substance use, as well as aging and HIV prevention. So, and I should mention that both the webinar and the workshop have interactive components that are meant to support practice-based learning. And the workshop also contains a reflective component to support a more sustained change in practice. And this involves us following up 6 weeks post-workshop to assess what changes have been made and any additional supports that physicians might need to make or sustain changes. So this is what we ended up calling our workshop, but I don't have any gay patients. And we did this deliberately to be a bit provocative. We wanted to, catch people's interest, but anecdotally and a little bit ironically, we were promoting this in a room full of physicians, and 2 of them piped up and said, "But I don't have any gay patients." And the positive outcome of that is we did get them to register for the workshop, and they will be coming. So it did really help us, reinforce our conviction that this really is a particularly timely kind of a project, especially when you're talking physicians in a metropolitan area who are just doing their jobs. We are actually in the process of delivering the webinar and the workshops right now. We launched the webinar on October 27th. If you're interested, you can take a look at it. It's archived on the UBC CPD website. That's the link there. And then we had 81 physicians register for the webinar, and of those 81, 59 attended. It's about a 70% attendance rate, which is about 20% higher than the average attendance to a UBC CPD offering, it's encouraging. It shows us that people are engaged, physicians are interested in wanting to learn. And so of the 59 who attended, 53 completed evaluation forms to give us a sense of who our audience was, as well as some valuable data for our evaluation. And so you can see that about 52% of the attendees were from the VCH region, with the other 50 being from all over, including other regions in BC and Canada, and we had 2 physicians from Iran. So we left the registration open to anyone because we wanted to get a sense of sort of what was the interest, not just within BCH, but going forward, looking with an eye towards expansion if there was interest from other regions. Which it brings me to sort of evaluation, and we're in the midst of delivering these, as I said, so we have some preliminary evaluation data to share based on the webinar. Since we wanted to be able to look at change in knowledge, the week prior to the webinar, we sent out a needs assessment to all of our registered physicians. This was voluntary, unlike the post-webinar evaluation, which is required in order to obtain the continuing medical education credit. So you can see that the response rate was definitely lower for the voluntary needs assessment, but not so low as not to be useful. So you can see that we had 30 respondents, 60% of whom were from the VCH region, and 83% of whom were family physicians. In the post-webinar evaluation, we had total respondents of 53, 52% of whom were from the VCH region, and 78% of whom were family physicians. So we looked at a number of different things around knowledge, comfort, and confidence regarding the provision of care for GBM-SM patients. This graph is looking at the change in knowledge, and you can see that it's quite striking in that prior to the workshop, 77% of respondents identified very poor to average knowledge, compared to 89% identifying good to excellent knowledge post-webinar. So you can see that even it's just an hour webinar, having that kind of access for physicians is quite valuable in terms of their own knowledge levels. This is looking at comfort level providing care, and you can see as much like the knowledge levels, there is a positive change. It's not quite as striking as the change in knowledge, which is understandable because it was webinar, which means the practice-based component is a bit smaller. Our hope is that many of those physicians will now come to the workshop and have an opportunity to really work on their own practices. And finally, we looked at confidence levels in the context of those learning outcomes that I outlined earlier. So you can see that on the whole, pre and post, there was an increase in physician confidence level in their own skills to provide care and understanding the impact of the social context of GBM-SM health, in their ability to identify common health issues, as well as being able to refer folks to appropriate resources. So on the whole, from a quantitative side, we've got some positive preliminary data. We're looking forward to the workshops so that we can see if these findings are reflected in the more in-depth work that we'll be doing with physicians. In addition to the quantitative stuff, physicians did identify a number of strategies that they were interested in adopting as part of their practice, and these are the ones that were most frequently mentioned. So strategies to make space more welcoming for GBM-SM patients, using gender orientation neutral sexual history taking strategies. So there's a lot of talk about not making heteronormative assumptions, and having more focus on other health issues, including mental health. And when we say other health issues, we mean looking beyond sexual health and treating folks as whole people and not just parts. So there are a number of conclusions that can be reasonably drawn from the data that our projects generated so far. And the first is that there's general physician interest in improving care for GBM-SM patients, which is encouraging. This interest is reflected in the attendance and participation in the webinar and registration for the workshop. And the initial data demonstrate that there's a general improvement in both knowledge and comfort levels in physicians who participate in CPD offerings. And as I mentioned, the workshop evaluation will help assess if change in knowledge and comfort will be reflected in change in practice, and that's the big question that we all have, because you can provide education as much as you like, but if it's not reflected in practice, then it only goes so far. And finally, we feel quite strongly that the preliminary findings suggest that we should consider a potential scale-up and replication of this project, at the very least province-wide, though we have had some interest from other provinces as well. So just in terms of next steps, we're going to be following up the webinar physician attendees with a survey just to see if they've made any changes to their practices. Our first workshop is November 26, 2015. It is, I believe, fully booked now, but we will be offering a final workshop in February 2016 as part of the pilot. That's all I have, so thank you.